time, but we'll have hopefully some time for discussion at the end of it. This is an important session. So the next presenter is Margarita Brida, who I consider her as the next generation of a leader. And she was a joint fellow between Munster, University of Munster, and us, supported by the Carla Bohm Foundation. And Carla is a guest of honor with us at the meeting, and we'll hear a bit more about her later on. So Margarita then went on to do her biostatistics course or degree in Harvard, and she's back in Croatia, where she's co-lead of HHD for the University of Zagreb and for the country. And probably she will prove me wrong, because she's presenting the obesity paradox with a question mark. Well, really. Thank you, Margarita.
Thank you so much, Professor Gatzoulis, for this nice introduction. I am truly very honored to be a part of this meeting, and really excellent talks and presentations earlier on, and yesterday really a very nice day. So I will start immediately. Let me see if I can share my screen. So can you see the screen now?
Yes, we can, Margarita. Go ahead.
Okay. So yes, as you mentioned, my talk today is on obesity paradox. I changed the title a little bit, so myth or reality, and it is a challenging topic, knowing, Professor Gatzoulis, your thoughts about having all our patients slim and athletic. But I will start slowly, and let's see how we go. So World Health Organization has defined overweight and obesity as abnormal or excessive fat accumulation that may impair health. And BMI is conventionally used as a simple index to assess patients for underweight, overweight, or obesity. And we know that overweight is defined as BMI of more than 25, and the obesity is defined as a BMI of more than 30. However, this BMI, it has to be stressed out, has its limitations. It is only a raw guide of body composition, and it does not have an ability to differentiate between fat, muscle, and skeletal weight. So individuals with the same BMI can have a very different degree of fatness. And today it seems it is all about pandemics, and obesity is also considered a global pandemic. Globally, it seems that approximately 40% of population is either overweight or obese. And we know that obesity is associated with negative health outcomes, and through various different pathophysiological mechanisms, it is a risk factor, as we all know very well, for various diseases. But regardless of these limitations that I mentioned regarding the BMI measures, it is a reasonably good measure of general adiposity, and the BMI is a predictor of overall mortality. And this is a very nice Lancet study that nicely shows the BMI associated mortality curve that is U-shaped for both men and women. And mortality seems to be the lowest in the BMI of 23 to 25, and it does increase with increased body weight, but also with a decreased body weight. So both in overweight and obese patients, and also in the underweight population. So one might think, okay, where does this obesity paradox actually come in? And it is a long-standing controversy, with studies demonstrated that perhaps the optimal body size is not the same for healthy, normal individuals and for those with a chronic disease. And it seems that in chronic disease, higher BMI is associated with a better outcome. And this is so-called the obesity paradox. The most favorable prognosis has been observed in just above the optimal BMI levels, so in overweight or mildly obese patients, that is class 1 obesity. So-called the reverse epidemiology, as some also call this obesity paradox, has first been observed in the patients with severe chronic kidney disease. These are patients on hemodialysis, but afterwards in the various different illnesses and cardiovascular disease. But what is in common in all these observations is chronic disease that is required. And another thing that is important to say, I think that epidemiological observations never prove causality, they proved association only. But then, you know, obesity paradox is now really everywhere. So look at this paper published this year in 2020 about diabetes and obesity paradox of more than 12,000 participants. Then obesity paradox, another very big study in atrial fibrillation. Obesity paradox is stroke, and especially in heart failure. And in 2001, this is a paper from 2001, Jack for the first time discusses obesity in a large cohort of patients with advanced heart failure. As you can see, he concludes that obesity is not associated with increased mortality and may confer a more favorable prognosis. And actually, after this paper, there were a lot of increasing number of publications on the same subject, coming to the very similar conclusion. And this year, we actually have this reinforced with a meta-analysis that was published in Heart. So, regarding adult congenital heart disease, and I like this paper very much. It was published some time ago by Professor Gatzoulis and Dr. Bolger, suggesting that congenital heart disease should be considered the original heart failure syndrome. And in fact, we know that heart failure remains the leading cause of death in this patient population. The percentage of overweight and obesity in congenital heart disease is actually very similar to the general population, and this holds true both for children with congenital heart disease and for ACHD patients. But there are some differences. For example, ACHD patients are more likely to be underweight, and ACHD patients are less likely to be morbidly obese. This is a Brompton study that we did some time ago about the BMI distribution and its association with survival in ACHD patients. We included more than 3,000 patients. And here you can also see that the obesity paradox holds true, and the higher BMI was associated with better survival in comparison with patients having normal BMI. But what is, again, I think very important to stress out, that underweight patients had in fact the worst survival. And if we look at the data more closely, this benefits of a higher BMI was especially pronounced in what we can call the sickest patients. These are patients with symptoms and patients with complex underlying cardiac defect, and also patients with cyanosis. On the other hand, when you look at the patients with simple underlying cardiac defect, they seem to resemble more the general population. So let's say the healthier population, who might benefit more, of course, from the lower BMI. Then we compared patients who maintained or increased their weight with those who exhibit weight loss. And again, the complex patients with a complex underlying cardiac defect who exhibit the weight loss, had actually the worst survival. And we couldn't find this connection with, again, simple cardiac defects. So I would say lower weight or unintentional weight loss is a bad news, and some people call this a lean paradox. And from this very nice paper, we know sarcopenia is common in complex patients with congenital heart disease, and that these complex congenital heart disease patients have altered body composition, and they have significantly lower skeletal muscle mass, and they have significantly lower muscle strength. And actually, approximately half of complex ACHD patients seem to be sarcopenic. And going back to this very nice meta-analysis, I think things can get pretty simple. So we know that in general, healthy population, with the increase of the BMI, there is a higher incidence of developing problems, different diseases, including heart failure. However, once we have a patient who has established heart failure, then it seems that this U curve that I showed you before from the Lancet paper is shift a little bit to the right. And it seems that the lowest mortality has been observed in the overweight patients. So not obese, but overweight patients. So just above the BMI higher of 25. And again, what seems to transpire in studies is that the worst survival is seen in underweight patients. So I hope Professor Grushin is going to forgive me. I took a liberty of saving his slide from his really excellent talk yesterday morning at this meeting, where he nicely highlighted the problems of cardiac cachexia and malnutrition, especially in heart failure population. And I think it is clear just by looking at this photo that if we have a patient looking like this in our clinic, that we would worry about this patient. And we know that the decreased BMI also goes with raised inflammatory markers. So, are there true protective factors of obesity? Well, one can argue that there is increased metabolic reserve during cachectic states. Then unintentional weight loss is a frequent finding in severe disease and may lead to malnutrition, which has negative impact on immune function. And fat reserve of obese patients may make them more resistant to the catabolic progression of the disease. And in chronic heart failure, there are studies showing only obese individuals had balanced muscle protein catabolism. And we know that unbalanced protein catabolism is associated with reduced immunological capacity and tissue integrity. And finally, fat tissue can also have some other potential benefits, the protection against bone fractures and infectious complications. So Stefan Anker, who used to come to our meetings in Dubrovnik, would say the fatter, the better, or big ships don't sink. So, but I think the jury is still on, and there are a lot of things that we still don't completely understand. And if you look, for example, at complex patients, adults with Fontan circulation, these are two very nice papers published the same year, you will see that there is a discrepancy in existing literature. For example, the first paper shows clearly that overweight and obesity is associated with symptomatic heart failure and a lower chance of survival. On the other hand, this paper that has included more patients showed that overweight and obesity in adulthood was associated with lower heart failure rates. So there is a discrepancy. But I think what Alexander nicely presented earlier on, that exercise is extremely important, and I will not go very much about this because we are going to have 2 more lectures in this sense. But especially in Fontan patients, if they have decreased muscle mass and muscle strength, this is obviously very harmful for them because they need to have a venous return that they can increase with muscle mass and in that way increase their cardiac output. But what I want to say that I think in all this story about obesity paradox, cardiorespiratory fitness is a fundamental part of the discussion. And this is a very nice paper. This is a large prospective cohort of patients with systolic heart failure that was divided by the BMI and the peak VO2. And again, the obesity paradox did hold true, and the worst survival was again observed in the lowest BMI. But what is very interesting is that excellent exercise tolerance modifies this connection between BMI and survival. And when BMI is adjusted by cardiorespiratory fitness, then the p-values are not anymore significant. In other words, the obesity paradox, the protective role of BMI disappears. So I think using adiposity to assess mortality risk may be misleading unless fitness is also considered. And food for thought, multiple potential reasons for this reverse epidemiology, if you wish. We mentioned anabolic deficiency and malnutrition, especially in heart failure patients with cardiac cachexia and sarcopenia. Then another very interesting thing is selection bias, survival of the fittest. In other words, obese patients we can expect maybe to die from coronary artery disease. So later on in our studies, we take obese patients, but who are, let's say, healthier. Treatment bias, another thing that probably there is a chance that we are going to treat more aggressively obese patients because of the multifactorial risk factors that then we are going to treat normal weight patients. And considering normal weight patients, there might be some still residual confounders that we haven't thought about and were not fully understood. Maybe there is cancer that we didn't know, or smoking. And on a global scale, social economic factors, the poorest, the most disadvantaged, are the leanest. And very shortly about modifying impact of metabolic phenotypes. This is a very nice study from Mayo Clinic that really describes these obesity phenotypes and connects this with cardiorespiratory fitness. And basically, when we think about obesity, we usually think about this gentleman on the right-hand side. So he has a BMI of more than 30, and this obesity is due to increased fat mass. However, look at those two other gentlemen that have also the BMI of more than 30, so we would say obese. But why? Because they have increased lean mass, so muscle mass. So we can imagine that their cardiorespiratory fitness is very different between the person on the right and perhaps these two people. So again, fat and fit maybe. So to summarize, obesity paradox has only been observed in established cardiovascular disease and severe chronic disease. It has never been observed in primary prevention. Obesity paradox is the strongest is just mildly overweight or mildly obese. It is a twist in the obesity story that does exist for sure, but we still don't fully understand. It must not be conceived as a promotion of obesity. There is no evidence that weight gaining is preventive for anything. Body composition, I think it's very important. So we need to differentiate what is fat and what is muscle. Obesity in patients requires appropriate therapy with lifestyle management, including physical exercise, aiming at physical fitness. And finally, what was seen also with Alexander, cardiorespiratory fitness is a better predictor of outcome than measures of adiposity and independently reduces mortality regardless of the BMI. So we know now that our patients should not perhaps look as skinny as this Victoria's Secret models, but maybe more like these ones. But in any case, they should be fit. Thank you for your attention.
Thank you, Margarita. It's an excellent talk, and we definitely want it in the journal as paper, and doesn't disprove the kind of dogma, if you wish, or the mantra of slim and athletic. And we'll discuss this at the end of the session. I appreciate you keeping on 20-minute slot. So